of talking just about the virus, the variants, the transmission that we had discussed, I'll go first back to the severity of the disease. So, and the reason for this is that we want people to kind of understand how do you distinguish between acute, moderate, and severe disease, and how would you change your management. So mild disease is basically when somebody has fever, malaise, cough, and upper respiratory symptoms. Upper respiratory symptoms means nasal congestion, sore throat, cough. These are the similar symptoms that you get with any kind of viral flu, which could be metapneumovirus or flu. During the flu season, there are a number of viruses. Sometimes it's rotavirus. So in mild disease, you are not having shortness of breath, which is dyspnea. So that's the main difference. And in moderate disease, you have all the above symptoms plus dyspnea. And dyspnea means you have shortness of breath. Now, it's considered severe. It's when the oxygen saturation has dropped below 94% and specifically below 88%. And if somebody has oxygen saturation below 88% at rest, that person is in the severe category now. Now, the difference, so in people who have mild disease, we have been giving in our hospital and all over America, we have been giving them monoclonal antibodies. And monoclonal antibody is not given to anybody who has oxygen desaturation. So we just admitted a patient 2 days ago who had come in for a monoclonal antibody infusion. But when the nurses checked his oxygen saturation, it was below 88%. So he was sent to the emergency room and then he was admitted. And then the treatment changes. And how does the treatment change? You have to give the person definitely oxygen. And then you would consider giving the person remdesivir, which we have been doing, and steroids, dexamethasone. That's the main thing that you would be doing. And I think dexamethasone has saved a lot of lives. It has improved condition of most patients who were put on it. We give 6 milligrams IV for 10 days. Sometimes in a patient who wasn't improving, we have given them a second course of dexamethasone. All right, so I am not sure here. I don't know if we can find out how many physicians are there on this talk right now and how many would have access to a ventilator. Can we get an answer on that? Sohail bhai, can we do that?
जी जरूर. तो अगर कुछ participants जो ventilator से come across करते हैं ICU में, can you just raise your hand please? ये वो भी एक topic हो सकता है ventilator management का if the participants deal with something like that.
Yeah, I think what I want to touch is who needs the ventilator and what is the criteria of putting somebody on the ventilator. That's what I want to touch here and discuss basically. So I think I see one person here who raised the hand. I don't know if I'm seeing everybody. Fiza Usman is one person.
जी आप unmute करके भी फिजा या जो भी है आप बात कर सकते हैं अगर if you would like to unmute him.
Well, basically I'm going to the persons who do not have ventilator in their hospital, this is what I'm going to tell them what would be the management. So first of all, if somebody has mild symptoms, yes, they can stay at home. They would be fine by just supportive care, and they would hopefully get better like most people do. A vast majority of people with COVID-19 mild infection will do fine at home with maybe aspirin, Tylenol, and just supportive care. Okay. Now the people who are persons who are having moderate disease have shortness of breath. Now, if they are not desaturating below 88%, they could or could not can or cannot be hospitalized. Now, here comes the main physiologic ramifications, I would say, of this disease. So if you are desaturating, your body will tell you to breathe faster. And when you breathe faster, you are able to keep your oxygen saturation at the normal level. This is a response of the body, a reflex of the body. And if we were to do an arterial blood gas on this patient, what are you going to see? Can somebody answer that? If you do an arterial blood gas on a person who's breathing rapidly, what would you see on the blood gas?
To see the respiratory acidosis.
Sorry?
Sir, to see the respiratory acidosis.
You will see acidosis. Okay. So this is what I wanted to.
Respiratory acidosis.
Respiratory acidosis. Okay. So interesting. I mean, since you mentioned that, that's actually what I'm trying to get to. So initially in the patient who's trying to maintain his oxygen saturation, you are going to see respiratory alkalosis. So what will happen is they will be breathing rapidly, and in that situation, they will be blowing off the carbon dioxide, and their PaCO2 on the blood gas will be low. It will be below 40. And their pH will be above 7.42. So this is one of the ways that you know that this person is trying to compensate. Now, if you look at the PaO2, in this person, the PaO2 may be in the normal range. If you look at the oxygen saturation on the blood gas or on the pulse oximeter, that may be normal. Now, what you have to basically understand is a person who is breathing rapidly is going to tire out, is going to get fatigued. And that is the point which you have to really look for. Is this person tiring out? Okay, now, in the first wave, when we had patients come in and we would find somebody who was desaturating, there were multiple issues. We did not know the disease. All the physicians, nurses, everybody was extremely concerned about getting the virus. So although we were using some PPE, we did not have PAPR. We would basically intubate the patient. They would go on the ventilator. In the second wave, and as we had more clinical experience, we were using high flow nasal cannula, which pushes oxygen with a high pressure through the nostril. And I think we will put a picture of the high flow nasal cannula later sometime. And that provided people with enough oxygenation, and we kept people on high flow nasal cannula for many days and while they were on the dexamethasone, and they got remdesivir, and then they slowly improved. And so initially, say if they were on 100% oxygen, they started going down after a few days to 90%, 80%, 70%, 60%, 50%, 40%. And at some point, they would switch to a nasal cannula. And then if they did really well, they would come off the nasal cannula, or some of these patients, because we were short of beds, we would transfer them home on oxygen 2 liters per minute via nasal cannula. But did we intubate in the second surgery? Yes, we did. So who do we intubate? So this is basically a clinical decision. It's based on some labs too, sure. Not here, but gas would be one of those. So since you had mentioned, one of the physicians just now had mentioned about the the respiratory acidosis. So if your PaCO2, which was low, which was below 40, now it starts to creep up. It's going in the opposite direction. It's going higher. It's becoming 41, 42, 43, 44, 45, 50, whatever. Now this patient has respiratory acidosis. This person is tiring out. This person is in a situation where now they are becoming critical. They are, and when you go to and ask the patient, are you having difficulty breathing? क्या आप थक गए हैं? क्या आपको थकन महसूस हो रही है? क्या आपको सांस लेने में बहुत दुश्वारी हो रही है? They will probably say yes. So that's that. Now this is the clinical. This is the point at where somebody's tiring out. You would definitely intubate the patient and put them on the mechanical ventilator. Now, I had some experience of having, as I think I had mentioned it on my last talk, of having a relative who was who had COPD, was a heavy smoker, was in one of the small towns in Punjab, and he what I've noticed was that there was extreme reluctance on the part of the physicians and the family of putting the patient on a ventilator. And the thought was the physicians were mentioning that to the family, and the family was hearing it from other people. Putting somebody on the ventilator means that they are going to die. So they were associating ventilator treatment or ventilator management or mechanical ventilation with death. Now that is totally wrong. What is ventilator support? Basically, ventilator is a support apparatus. So if you are tiring out, you are going to fatigue, you're going to go, your muscles are going to become fatigue out, and then there is a high chance, because your heart rate is up too, you can end up with a cardiopulmonary arrest. That is a code situation. We call it code blue. I think you have the same term there. And then you would have to urgently or emergently intubate somebody. You may have to shock, you may have to do other things, you may have to do CPR. So it is important to prevent this. Now, at this point, I think, Sohail bhai, we should take questions from anybody who has a question on what I just mentioned. Does anybody have a question on this?
I think आप लोग अपने experience से related भी question कर सकते हैं जो इस topic के around हो. अगर आपके hospital में experiences हैं COVID patients के साथ या outpatient में.
Especially on the ventilator, like when what I'm trying to get to is, what I'm trying to say here is, a person who's tiring out, a person who has been on 100% oxygen, respiratory rate is high, the person is getting tired, fatigued, their PaCO2 initially was low, it's creeping up, they're having difficulty, they are not able to ventilate, their oxygenation may or may not drop, they are becoming acute, they should be intubated and mechanically ventilated. Is that kind of clear, or somebody has any question on that? I don't see anybody asking a question here, right? So by anybody is asking a question on this?
No, I think we can continue.
Okay, so so that's basically one of mechanical ventilator. There's something other thing which is short of mechanical ventilation is a non-invasive positive pressure ventilation, where you are putting a tight fitting mask on the face and pushing air under pressure. It's BiPAP. Usually you can use CPAP. So in BiPAP, you have two pressures that you're using. There's inspiratory pressure and an expiratory pressure. Usually we start with, say, 10 inspiratory pressure, 5 expiratory pressure. But initially in with the COVID patients, this was contraindicated in all hospitals. And this has kind of remained controversial and remained a treatment that has not been used. The other thing that we had changed during COVID was like we would have COPD patients or patients who would need bronchodilators. In those patients, nebulizer treatments were all stopped because of the thought that the droplets from giving nebulization would be all around in the air. The rooms, although were changed into negative pressure by putting high-powered exhaust fans with HEPA filters, but still people were being given and are still being given meter dose inhalers. The meter dose inhalers are thought to be safer because the droplets remain in and very little droplets are going to come out and cause contamination in the air or infectivity from the droplets. So that's another thing. Now, I think I wanted to also discuss something about the chest x-rays and radiology. Silva, can you put up that chest x-ray? That was one picture I had. Oh, there's a question coming in from Adaya. People have been using nebulization. Is it recommended? No, we are not using nebulizer treatments. We are doing meter dose inhalers with the concern of thing. In some situations, we are using nebulizer, but if nebulization treatments are used, we're trying to avoid them basically. But if they are used, there is a sign outside on the patient's room that patient has been given nebulization treatment. Nobody should enter the room for, I think it's 3 hours they are putting in, but which is a long time. Other things that were being used during the COVID treatment were people had cell phones or iPads, and they were communicating with the nurses or with their family members through them. So there was less contact between the patient, or people getting exposed to the environment inside the room. There's another question. Thanks for clarifying. I have been telling me this to patients, but they say hamara doctor ne bataya. Okay, so going back to the nebulization. Some people use nebulizer treatments at home. At home, if you were to use nebulizers, you would probably be causing a lot of dispersion of the droplets in the air. And if other people are coming into the same room, they're not wearing shields, eye protection, N95 mask, proper, so then they are definitely going to get exposed. So other family members in the house will get exposed to the droplets and can get the infection. Now, as we know from this, I would call it probably like this third surge or whatever. Right now in Florida, younger people have a lot of COVID infection. So no age group is spared. So younger people, 19, 25, 19 to 35, 19 to 40, or even younger, below 19 children have been getting COVID infection too. So it's a disease that is not sparing the younger population too, especially now with the Delta variant. So to keep the exposure minimum is probably the best thing. Any other question? Okay. All right. So chest X-ray, Selvai, can you put the chest?